Hi, Dr. Meredith.
Good afternoon. How are you?
Good. How are you?
Very good. Thank you.
I want to introduce Dr. Meredith to the group. Dr. Meredith is a neuropathologist and associate professor in pathology in Brigham and Women's Hospital. He's also assistant professor in Harvard Medical School and from Boston. He did his residency and 2 fellowships from Brigham and Women's as well. And he was very kind to join us for our neuropathology sessions. We really look forward to learning from him.
Thanks so much for having me. It's a pleasure to be able to join in this very interesting forum. I'm glad to be a part of it. So while we're waiting on the few others to join up, do we have a sense of how many folks we're going to have this afternoon?
I would think around anywhere from 12 to 15, 12 to 25, anywhere from 12 to 25 is our average.
Great. And do we have a sense of kind of what level of trainees are we hosting?
So we do have residents, we do have fellows, we do have some practicing pathologists that have been practicing for anywhere between 1 to 3-4 years. And yeah, those are our major group.
Sounds great. Well, we can let everybody kind of continue trickling in, and when you think we're about ready to get started, I can share my screen and we can take off from there.
Sure, I guess you can share your screen and we can get started, and people keep on coming in.
Sounds good. If you want to stop sharing, I can jump on there real quick.
Sure. There you go.
Can you enable screen sharing?
Now it should be good.
All right, perfect. All right, can everybody see the screen okay?
Yes.
Great. So I had thought, you know, the field of neuropathology obviously is extraordinarily broad, and there's no shortage of topics that we can cover. And even a week is a fairly condensed time frame in which to cover even all the material that's on this online forum. So I thought one of the first things we could do is just deal with a lot of the neoplastic entities. It's certainly one of the most you know, common series of specimens that we encounter in surgical neuropathology. We can just kind of go through a couple of themes with gliomas and I think meningiomas, and then if anybody has any kind of pet diagnoses they want to discuss, we can certainly open it up to the group. But I think that's probably a good way to start for today. So shall we go ahead and get started then?
Yes, please, go ahead.
Sounds great. So let's see, I didn't save any images. I was just going to kind of peek through some of these. You know, I think one of the far and away, I think I'm just sharing my browser. Is this other window still displaying for everyone?
Yes. Perfect.
So high-grade gliomas, glioblastomas in particular, are by far and away one of the bread and butter topics that we encounter most routinely. Most of these patients present fairly emergently with most often ring-enhancing lesions somewhere within the cerebrum. And these are always surgical issues, and they can present in a number of different ways and have different histomorphologic appearances. But there are certainly some themes that are no doubt common amongst all the different types of cases that we run across. So just starting off with low power, here's you know, one such example here. We can obviously see that there's you know, a nice dense focus of tumor in the lower left portion of the field, and there's some adjacent brain tissue that we'll take a look at a little bit closer, but we can already see from this power that there's areas of necrosis. So there's really no doubt whatsoever that this is a high-grade malignancy. As we get in a little bit closer, now we can see the interface with the adjacent normal brain tissue, and we can see that that the tumor is infiltrating, very, very much in a gradient-like fashion into the adjacent gyrus brain tissue. And that gives us high confidence that this is a glial neoplasm. We can also see that there are these very large vessels adjacent to the tumor mass. So this tumor has actually escaped from the brain parenchyma and is now crawling within the leptomeningeal space, something that is not uncommon for glial malignancies. And then as we get in a little bit deeper, one can certainly see the high-grade atypia that's present within the tumor cell nuclei. You can see the glial processes coming off many of these cells. You can see the nice, very picturesque regions of palisading necrosis. Glial tumors are especially notorious for this. So you can see that the tumor cells are condensing around these foci of micronecrosis. And then if we were to get lucky somewhere in the parenchyma, we might be able to see some of the basis for these microscopic regions of necrosis, the unusual vessels with the endothelial hyperplasia that frequently have microthrombi within them, leading to downstream necrosis. But that is certainly not necessary to make the diagnosis. So I think this is a really easy, kind of nice example to get our feet wet. This is usually not too much of a diagnostic conundrum, especially when you have a nice resection specimen like this. I just wanted to see if there was anything else of note in this particular slide. While I'm just kind of driving around, seeing if there's anything else worth noting. Does anyone have any questions over this case?
So you said it is going towards the leptomeningeal space. Can you elaborate more on that?
Certainly. So this is a pretty good specimen in terms of its orientation. So if I zoom out just a little bit, you can get a sense of kind of the architecture of the specimen. I might just rotate it a little bit so we can get a sense. So this is the very top of the brain. So this area right in here that I'm indicating with my cursor is all gray matter. So this is the cerebral cortex. You can tell it kind of has this vague 6-layer lamination pattern. It's not the easiest to make out unless the brain is particularly well oriented, but you can kind of get a sense of a hypocellular zone here, a more cellular band, and then there's kind of alternating zones until you get down to this very edematous, more eosinophilic region adjacent to this, which is the white matter. And over off to the side, you can see the tumor, and then on top of this brain, all of this loose connective tissue is all meningeal. And the brain does not have these large caliber vessels within the parenchyma. If I actually get in a little closer, you can get a sense over here of what normal vasculature tends to look like within the brain. Because it's a little congested, it makes it easier to see. So a lot of these very thin, delicate capillaries are the predominant vascular source within the brain parenchyma, and there's some slightly larger venules and arterioles. But that's about it in terms of vascular caliber within the brain. So whenever you see these big, large muscular arteries and veins within a neuropathologic specimen, we always know we're outside of the brain tissue proper. And so, especially when we come over here, and now it's just a swarm of tumor and without much recognizable background architecture, we see these large vessels that are not obviously neoplastic, part of the tumor-induced vascularity, and then it's reasonable to infer that these are all of leptomeningeal origin. And this is,
thank you.
Of course, and this is a fairly common finding. Sometimes it can be especially prominent and mimic primary leptomeningeal diseases, but usually there's pretty good evidence of a parenchymal source. But just to point that out.
I have one more question. When you get frozen sections for them, like what is the clinician wanting us, like from us to answer, and how do you write your frozen section report for them?
Great question. I think The answer really depends on your clinicians. I think in general, whenever we get these for frozen, there's usually a couple of pieces of information that are of interest. Number one, am I in the lesion? This is more of note when you're in probably lower grade tumors where the distinction with normal brain tissue is more difficult. But some of these tumors have a fairly broad differential series of potential radiologic mimics. Most lesions in the brain will present as some sort of contrast enhancing lesion. So if the patient has another oncologic process in their history, or is this a potential metastasis? Is it a primary glial tumor? Is it an abscess, et cetera? So just kind of knowing, is this a malignancy that should be resected is of importance. And of course, the main distinguishing differential consideration in that regard would be lymphoma. Lymphoma characteristically is not considered a resectable lesion. Some modern studies are debating that a bit, but by and large, that's the teaching, and most surgeons will operate in that manner. Second of all, they're depending on the size of the center. If it's higher volume, more academically oriented center, they may be wondering, is there sufficient tissue to do ancillary molecular testing? That's frequently what we get, or if there's a tissue banking question, for example. And then in terms of wording frozen section diagnoses, I think by and large, most surgeons just want to make sure of those kind of two things. Is this something that they need to resect? So is it a tumor or not tumor? And after that, it's kind of lesser importance. This tumor is kind of interesting, so I wanted to show you a couple of things, and then we can discuss that point just a little more in depth. Let me see if I can find a good region. Well, we'll just start right here. So as the name suggests, glioblastoma multiforme, these tumors can have a fairly wide-ranging array of histomorphologies, and it's just kind of worth pointing some of those out in case you run across some of these and just kind of realize that glial tumors can have a pretty wide-ranging morphology. So here's an example. It's kind of got this little small cell change focus, so if one was considering a tumor that might make sense in that differential, that's something to consider. Here's a region that's more epithelioid. The patient had a melanoma history or suspicion thereof. One might be, cautious in calling this flat out glioma without more information if this is, the only field you had.
Yeah.
So, I usually am pretty definitive. High-grade glioma, epithelioid neoplasm, spindled neoplasm. It doesn't matter too much as long as they know that they have tumor that they can cut out. Excuse me.
Okay, thank you.
I have a question. Do the morphologic differences, as you said, small cell pattern and the others, do they carry any prognostic significance in our reports?
Not usually. The only caveats might be, in select demographics. So for example, we were, looking at a tumor that was high grade like this in a, 30-year-old patient, for example, we might consider an IDH mutation as being an underlying genetic feature. In those cases, tend to have superior prognostic courses for those patients, but that's something that would require ancillary testing. So on morphology alone, there's really no correlation with natural history, but if it looks like it's high grade and glial, then there's no need to go beyond that.
Right.
Excuse me, just getting over a little cold here. Pardon me.
Does anyone have any other questions?
Yeah, one more. Do we mention if we see atypical mitosis and necrosis in the frozen report, like frozen section report, and does that help to guide towards it's a high grade neoplasm or not, or those things the clinician is not that interested in?
So again, it kind of depends. So I think for me, what I'm most interested in at the time of frozen is what I'm seeing, nicely representative of the radiology. So if there's a big enhancing lesion in the brain and you see something that's, let me kind of zoom out here. And you get a piece of tissue that looks like that, I would ask for more tissue and just kind of communicate to the surgeon that you may not be in the, most representative piece of tissue. And if you need to do further, downstream study and proper workup, this is not going to, be the most, useful specimen. Whereas if the radiology is much less, indicative of a lesion, then something like this might be appropriate. So making that correlation is helpful.
Okay, got it. Thank you.
Excuse me. Okay. So by far and away, these are going to be tissues that we or cases that we see most often. So I figure it's probably worth hitting this up first. Why don't we jump to something a little more subtle now for contrast? Let's pull up. Let's see what else we have in the bank. Just kind of zoom in and make sure this is what we want to look at. Yeah, this is great. Okay, so now by contrast, this is a piece of, this is a resection specimen. Again, we have cortex. From low power, we can kind of make out the ribbon of gray matter, the underlying white matter. We have a few fragments here. It's awfully pink. So even from low power, the idea is we probably are not dealing with a high-grade tumor here. But we can see a little bit of edema in the background, some of these white space in the white matter. And so if one is looking at pre-surgical imaging, this frequently comes across as T2 hyperintensity. Excuse me. Of course, now we're here at the end of the day and I have given a presentation. I'm getting all choked up here.
If you want to take a couple minutes break, we can take a couple minutes break.
We'll soldier through. So this, by contrast, is going to be a lot more subtle lesion. So if we go in to the white matter where most gliomas originate, we can now get a sense that, in contrast to this previous GBM that we just looked at, this is a far more subtle appearing lesion. I think you can probably get a sense that the cellularity of the brain tissue is perhaps a little too high. We'll look at a normal section of brain next just to give you a comparison. But it looks like there's too many cells. All this white space in the background is abnormal. It's a common feature of low-grade glial tumors. And you can see a few cells that look a little unusual. So here, for example, is a cell with some hyperchromasia and a little bit of a nucleus. And in general, one can rely on the fact that most neuroparenchymal cells do not like being next to one another. So when you see them beginning to aggregate, pile up on one another, It is not a normal feature of most brain tissue. And then as we get out into the gray matter, you can now start to see some of the neurons in the background, some of these bigger cells. We can again start to see kind of a gradient effect for some of the higher cellularities here in the white matter. And we can see some of the cells beginning to trickle along vessels and neurons as well. Try to convince you of some of these features here. This is admittedly a subtle finding. But this is a feature known as satellitosis. So many glial cells, neoplastic glial cells, like to track along existing structures, vessels and axons. And that can be one clue that one is looking at either the edge or a low-grade glioma, such as I think we're dealing with here. So let's see if we can find any other regions of interest in this one. Just looking at the kind of sparse cellularity in this case, I'm guessing it's going to be difficult to find mitotic figures, and certainly evidence of higher grade tumor transformations such as necrosis or endothelial hyperplasia is probably going to be absent. But it certainly doesn't look like we're running into many candidate mitotic figures in the scanned image. So this is a very, very low grade tumor, and one that would probably be very difficult if one was looking at biopsy from the periphery of this tumor. So hopefully this is not a specimen that one runs across very frequently. It can be awfully challenging on frozen for sure, especially in the absence of obviously atypical cells in the background.
I have seen them resecting more of high-grade gliomas and glioblastomas. I mean, how frequently do they resect the low-grade if they know that it is a low-grade? I mean, radiological features that are suggestive of low-grade.
Yeah, so by and large, most of the low-grade gliomas are going to be usually mutated for IDH1 or 2. And those tumors, really the standard of care, excuse me, is going to be surgical therapy. So if one can achieve a nice gross total resection, those patients are going to be well primed for good outcomes. So surgeons really try as much as possible to get as much of these tumors as possible, providing they're in an anatomic region that's permissive for that. So, if it's not a non-eloquent region of brain, for example.
Right.
But just to kind of show you the morphologic spectrum, here's a good example. This is what I'm looking for. So here's a great example of satellitosis. One can see the tumor cells crawling along the length of this vessel here. So that's a nice indicator there.
In frozen sections, if you see such kind of crawling along the blood vessels cells, does it ever make confusion between lymphoma versus this? It might be very primitive for you, but sometimes.
No, it's a good question, and I think it kind of depends on if you're able to do an intraoperative smear, which we usually do in addition to the cut frozens, and in many of those instances, one can see that the cytoplasmic processes for many of these cells have nice long fibrillar processes and not kind of minimal cytoplasm like you might expect for lymphoma.
Right.
Is lymphoglandular bodies an entity in CNS lymphomas too, or no? It's like that's
absolutely.
It is, okay.
Absolutely, it's one of my most favorite diagnostic features when looking at a smear. For sure, it can be very helpful. We might transition to a lymphoma. I can just kind of show you an example.
Yeah, that would be good.
Sure.
See what we have here. It's going to be a sheet of tumor. This might be more challenging. Let's see if we have one that's a little more diffuse. This is about the size of a specimen we get for brain.
Mm-hmm.
So the majority of the CNS lymphomas are going to be high-grade B-cell lymphomas, like the overwhelming majority. So it usually will not be too diagnostically challenging. And then especially the atypia in these cells is quite severe compared to that in some of the lower grade gliomas. But these are certainly another tumor type that can diffusely infiltrate through the CNS, much like a glioma would. So it can certainly mimic that if the sample is just right. These cells are very large and ugly, and usually wouldn't be too much of a difficulty distinguishing this from a low-grade glioma. Do you actually mind if I take about 2 minutes here, just real quick?
Yes, please do.
All right, thanks so much.
I'll stop the recording meanwhile, and when you start, I'll start the recording, okay?
All right, thanks so much. Okay, let's try that again. All right, let me jump to, see if we can just pull up a normal section of brain here just for comparison. This one isn't totally normal, but we can just kind of use it for comparison. So this is a section of medial temporal lobe, but at least it does have gray matter and white matter. And this will give you a sense kind of for what normal brain cellularity tends to look like. So up here in the gray matter, we can see a number of the big pyramidal neurons, but more importantly, just kind of paying attention to the background neuropil. It's just this nice fine velvety appearance. And one can see that most neurons are associated with one or maybe two satellite cells. These are myelinating oligodendrocytes. And then one can see the occasional slightly larger oval cells scattered throughout, and those are probably astrocytes. But this is kind of what we expect for more or less normal tissue. And then as we get down into the white matter, all of the axons are running through here, so the background's slightly coarser. And kind of make out some of the individual axons running through the tissue. And you can see that there's a higher proportion of glia down here. There are the occasional neurons. But this is about what we expect to see for most normal tissue. So this is kind of a nice frame of reference that I just wanted to show, so that, you know, when we look over here for this lower grade glioma, for example, you can kind of get a sense that, you know, there just are a few too many cells, and that's kind of, you know, a good frame of reference for that. Kind of back and forth at the relatively same magnification. So while this is a subtle finding, you know, if you see too many cells like this, you can just, you know, comment that it looks like hypercellular white matter, and maybe there's some atypical cells, and that's about as far as we're going to go without any more stains or studies to help us out. Okay, any questions over those before we move on to something else?
Yeah, do they have touch preps or you know, the cytology slides, if at all? That would be nice to view at this time.
Of cytology slides of gliomas?
Yeah, like the ones that we create by frozen section.
Let me see. Here's
There's a
I don't know that they had many. Some of them look like they may be other tumor types. While this is labeled as an ependymoma, which is a type of glioma, it does give you a really nice sense of what these cytoplasmic processes look like. You can see how they just have that really nice stringy quality to them. And while the nuclei may differ from tumor type to tumor type, this appearance, with the fibrillar stringy processes is going to be fairly uniform amongst all the different glial types.
Mm-hmm.
So for me, this is very helpful. If I see this, I know instantly I'm dealing with a glioma of some sort.
Mm-hmm.
And that's usually sufficient for any surgeon. This is really nice. Just that really nice, kind of strung out cytoplasm.
How do you differentiate from a squash artifact, like the cytoplasm is not like stretched while making a squash paper?
By and large, if you squeeze hard enough, you can make just about any artifact, but with just enough pressure to kind of disaggregate the cells and kind of smear them along the length of the slide, most epithelial type tumors will retain their cytomorphology pretty well. Lymphomas, as we were just talking about earlier, tend to have more delicate cytoplasm, so they can shed that fairly easily with the mechanical stress of the preparation. But by and large, most other tumor types or tissue types that one would be considering will be relatively well preserved. And even if, in some of the areas such as this, where, maybe there's, fewer cell aggregates, and so they're more air dried or squished, usually you'll have some more intact tissue aggregates that one can see with the intact cytoarchitecture a little bit better. So usually it's not too difficult, especially given the minute size of many of the neurologic specimens that we get. This is an extraordinarily useful preparation. So I rely on it quite heavily, and I think getting used to looking at specimens like this can do wonders.
Thank you.
Of course. Let's now compare this series of tumors with an oligodendroglioma. So this looks like this is going to be a nice prototypical example of one. We can already see from low power that it's very pink, so it's probably not going to be a very high-grade tumor. You can see numerous dystrophic calcifications distributed all throughout the piece of tissue. And then as I zoom in, see if we can find the characteristics findings here. So all of these cells are comprising this tumor, have this very nice kind of fried egg appearance. Most of the nuclei are very rounded, they're very monomorphic, in a very, kind of powdery, finely distributed chromatin, and of course the perinuclear halos that fully encircle the nucleus. Is a highly characteristic morphologic finding in oligodendroglioma. So the last couple of tumor types that we've looked at have been astrocytomas, GBM being the prototypical high-grade astrocytoma. And then we saw a lower grade astrocytoma, which can be awfully subtle to pick out. But oligodendrogliomas tend to be a little more picturesque, mostly because of these perinuclear halos and the very monomorphic appearance. They tend to stick out a little bit easier from the background. And when cases like this have the dystrophic calcification, sometimes even on imaging, the radiologist may propose that such a tumor is of oligodendroglial lineage. Nowadays, we don't make this diagnosis without ancillary molecular testing. So this tumor type is now, by definition, requires co-deletion of chromosomes 1p and 19q. And we certainly will never make the diagnosis on frozen section. The halos are an artifact of processing, so one does not see that at the time of frozen section. But there are some histologic mimics that don't carry the same very favorable prognosis as, the abundant calcifications, kind of portend that this is a very indolent growing lesion. And so without ancillary studies, we might just call it a low-grade glioma with oligodendroglioma-like features or something along those lines. But certainly want to have that confirmation before signing this out as definitive oligodendroglioma. But just kind of give you an overview of the morphology. These are really the two big categories of diffuse gliomas. Diffuse meaning they're infiltrating throughout the brain tissue, as we've seen. And these are, by and large, the most common tumors that one runs across in adults of primary CNS origin anyway. So, astrocytomas and oligodendrogliomas of different grades. And this is a very characteristic example of an oligodendroglioma. Any questions over this? So when it comes to grading, I'm sorry, go ahead.
While you're at it, can you also tell the features of anaplastic oligodendroglioma?
Absolutely. So when thinking about grading, we've seen some of the features of high-grade gliomas, so namely necrosis, the microvascular proliferation, and elevated mitotic count. And the same is certainly true with oligodendrogliomas. So oligodendrogliomas, and in fact all diffuse gliomas, begin at a WHO grade of grade 2. So the WHO scale goes from 1 to 4, 1 being essentially equivalent to benign or surgically curative, 2 being low-grade malignancy, 3 a kind of intermediate or higher grade, and then obviously grade 4 is reserved especially just for glioblastomas as far as gliomas go. And the survival for each category gets obviously significantly worse. So oligodendrogliomas start off as grade 2, so that's the lowest they could be, and this looks like this would certainly be a low-grade oligodendroglioma. So we're not expecting to see necrosis or microvascular proliferation, and as I've been driving around this large piece of tissue, we certainly haven't seen any of those. But the definition between the cutoff between a grade 2 and a grade 3 or anaplastic oligodendroglioma is not perfectly set in stone like it is for astrocytomas, for example. Some have proposed mitotic count cutoffs of 6 per 10 high power fields, anything above that being grade 3 and below that being grade 2. I think we frequently run into borderline cases. One can certainly see very densely cellular grade 2 oligodendrogliomas, but without a high mitotic rate or some of those other high grade features, one would not want to call that as grade 3. I like to be able to see vascular proliferation, and if the mitotic count is extraordinarily high, over 10 per 10, then you're certainly on very solid ground. Truthfully, the survival differences between grade 2 and grade 3 oligos is not terribly dissimilar, so there's not a ton of incentive on landing on that a given cutoff. I think it has more to do with other genetic determinants. But for astrocytomas, by contrast, those have a much more cut and dry grading scheme. And so I was going to show you a couple additional examples of that. Any other questions on this oligo before I leave this slide?
How is the management different if you call it like grade 2 versus 3 and higher like grades?
The canned answer is there is none. Almost all patients with these gliomas, irrespective of grade, are going to get surgery, and then a combination of temozolomide chemotherapy and radiation treatment. The difference may be if one is dealing with an especially young patient with a more indolent tumor such as this. Some oncologists may favor just doing a gross total resection and then sparing the patient any kind of chemoradiation therapy for as long as possible, because tumors such as this one that we're looking at are fairly slow growing. You know, a patient with a good resection may be able to go 15, 20 years without needing any additional therapy. So the younger a person is, the more life that an oncologist can spare them, you know, potentially brain damaging radiation or chemo, the longer they'll try to do so. But in general, you know, agnostic of those special clinical considerations, they're all pretty much treated the same. So there's not a huge incentive to try to be super nitpicky about grading these, especially when the survival differences are kind of you know, a little borderline in terms of their differences. So,
Okay, thank you.
of course. Any other questions on this case? Okay. Doesn't look like we have any good ones. Let me take another look. I thought we had some higher grade astrocytomas that I wanted to show. All right, this one looks like it's probably pretty good. So now this is, you know, if the slide diagnosis is accurate, then we're considering this to be a grade 3 astrocytoma. So in comparison to the two previous astrocytomas that we've seen, cellularity here is a little more intermediate, certainly not very subtle, I think. We can see a number of these, you know, kind of gonistocytic or epithelioid forms. This is a common morphologic appearance of these kind of intermediate grade astrocytomas, is this gonistocytic type appearance. We can see background neurons, so we know that this tumor is infiltrating through normal brain tissue. The cells are kind of piling up on one another, and they show fairly atypical hyperchromatic nuclei, all of which are characteristic features of astrocytic lineage tumors. And I'm sure if we look hard enough, we probably won't have difficulty finding mitotic figures. But at least on review of the slides so far, we don't see any necrosis, nor definitive microvascular proliferation. So in the absence of either of those two histologic features and overt mitotic activity, something in the range of, you know, 1 to 2 mites per 10 powered fields or greater, then we feel comfortable grading a tumor such as this as a grade 3 anaplastic astrocytoma. And there really is no upper limit for the mitotic count until they get one of those grade 4 features, being necrosis or the funny vasculature. You know, then they remain grade 3. But this just kind of gives you a broader overview. Something that looks obviously neoplastic, obviously, you know, not quite as low grade, especially if we found some mitotic figures, but certainly not quite to the level of the GBM. So this would be, you know, a nice representation of a grade 3 astrocytoma.
So I have seen the gemestrocytic astrocytoma. I don't know if it is still called as gemestrocytic astrocytoma, if there are certain number of gemestrocytes. Do we make that diagnosis anymore, and does it carry any significance?
Not terribly. What I was going to try to look around and see if we could see a normal reactive astrocyte in the background. Here's probably a good example. It's, you know, probably not the best representation, but you do see some of these cells that kind of have the abundant eosinophilic cytoplasm, but the less interesting nuclei, especially compared with tumor cells such as this. And these cells are just trying to recapitulate normal astrocytic phenotype. They're obviously not successful in that regard, but it just kind of gives you an indication if they are astrocytic in lineage. Most of these gemistocytic, dense tumors are IDH mutant, and so that can be helpful, but it's certainly not an entirely specific morphology. So, when we're looking at these lower grade tumors, there's a high probability that there's an underlying IDH mutation, and we'll screen for mutation in IDH in pretty much every glioma, irrespective of morphologic appearance. But if one had to be more judicious about triaging tissue, then an astrocytoma with this kind of appearance would be higher likelihood to carry such a mutation compared to that first GBM case that we looked at, for example.
What immunos do you routinely do with these cases, like Olig to IDH1? Is it a panel that you have to do on all the cases, or it's like, how do you approach that?
Sure. So it kind of varies based on the appearance. So I did want to go over some basic kind of molecular discussion, since it's permeated our field so thoroughly at this stage. But for GBMs, such as the first case we saw, I think just doing an IDH stain, or if somebody has rapid ddPCR analysis, whatever the institution has available, is usually sufficient for screening purposes. And if that's negative, we usually won't bother with any other IHC unless one, we're considering other entities in the differential that were non-glial. For lower grade gliomas, one can actually use a broader panel of mutation. They're not all mutation specific antibodies, but mutation assessing antibodies to help land on one diagnosis or the other. So for example, astrocytomas that have IDH mutations tend to have a triple mutant phenotype that includes ATRX and P53 mutations. Let me just see if I think I remember there being an IHC image in somewhere in here. Okay, this is a good image. So in addition to having positivity for the IDH R132H mutation-specific antibody, astrocytomas in particular tend to have loss of ATRX. So here's a good example of ATRX, which is nicely positive in the nuclei of the background non-neoplastic cells, but in the big neoplastic tumor cells, it's obviously deficient. So that's the concert of those two antibody results would be nicely specific to make the diagnosis of astrocytoma without needing FISH or more comprehensive genomic testing for 1p19q status, for example. For oligodendrogliomas, it becomes more difficult because the cells have retained staining and may or may not have IDH staining, because they can have different mutations at that codon or at IDH2, which tends not to be covered by our antibody. So a negative IDH result may not necessarily indicate absence of all possible IDH mutations. So, but astrocytomas, because they can have the loss of ATRX and are more commonly mutated for that R132H mutation, nicely have that combination of immunofindings. So that can certainly be helpful. As for the other, kind of sort of lineage-specific markers such as GFAP and OLIG2, I think that's individual specific. Like I said, if you were considering other entities in the differential, those are certainly highly recommended. But as a routine tool for gliomas, that's not something we necessarily always do. But that is definitely an individual preference.
Okay, thank you.
Of course. And we're not just discussing this or showing examples, but many people will also use Ki67 as an ancillary marker, especially for the lower grade tumors. For that first case, or this second kind of low grade astrocytoma, this might be a case that would be a great candidate for doing a Ki-67, just to make sure that the cells that we're looking at are in fact cycling, and give you higher confidence that this is in fact a neoplasm and not, some kind of reactive process, which can certainly be a challenge if that's a consideration.
Sorry, do you do P53 too often or no?
For the astrocytomas, we will if we're considering the IDH mutations, because that's the other mutant trifecta. So they will have strongly upregulated diffuse P53 positivity. So the combination of IDH positivity, ATRX loss, and strong diffuse P53 positivity really nails the diagnosis of an astrocytoma, irrespective of grade. So an oligodendroglioma, by contrast, should have ideally positivity for the IDH stain, with the caveats that I mentioned that there could be other mutations at that codon, but should have retained ATRX and low or negative P53. So that can be helpful in that regard. If one is looking at a glioblastoma that's not, diagnostically as challenging, it doesn't have as much utility. So we tend not to do it in that regard. But to distinguish the two types of lower grade gliomas, that certainly is very useful.
Thanks.
Any other questions on that? All right, we have a few minutes remaining. Does anyone have any cases or diagnoses that they'd like to review in the last remaining minutes?
Maybe we can see anaplastic oligodendroglioma if they have it, because we already reviewed the oligo.
Let's see if they have that. This one looks promising. It looks very blue. Okay, so just kind of starting over here. This is the very conventional oligodendroglioma morphology. You can see the little halos, the satellotosis. All of these cells are percolating around background neurons and vessels. You can see the calcifications. These are certainly not present in all tumor types. It's probably less than half have them. So when they are present, it's nice, but it's not always there. Then let's see as it gets more densely cellular over here. Okay, this is a nice kind of transition to a higher grade oligo. So you can see just in one field something that looks more grade 2, and then off to the left, highly densely cellular tumor. They can start getting so densely cellular, it kind of loses that fried egg appearance. And sometimes I think these can be a pretty good mimic for lymphomas, especially when they get very, very densely packed together and unfrozen, because the processes for oligodendrogliomas can be a little more delicate than for astrocytomas. So it can be just a little more subtle, although they should be there ideally. I'm just kind of hunting around to see if there's appreciable mitotic activity, but just on an H&E appearance alone, this kind of degree of cellularity is certainly in keeping with a higher grade oligodendroglioma, and they can begin to get more pleomorphism, nuclei. They can become spindled and have multinucleate forms. So in the highest of grade oligos that have really acquired a number of bad genetic lesions, they can be quite ugly in appearance. This one still has that rounded cell appearance. It's fairly characteristic of oligos, but certainly more cellular. And my guess is that if we were to spend time hunting, we'd have no trouble finding a number of mitotic figures. But this does not quite to the same degree of a glioblastoma. Let's see if there are any other examples here. This also kind of gives you a sense of the natural history, because they just kind of tend to form these little nodules in the bed of tumor resections over time. So frequently just very, very kind of focal. entities. It's rare that an oligodendroglioma will start off life as a high-grade tumor. I'm just looking for vascular proliferation in some of these specimens so I can show what that looks like in a more concrete fashion before we conclude. This is not the most picturesque. You can see some of these vessels have these big open chromatin endothelial cells, so they're not entirely normal and maybe leaking contrast, but they're not multi-layered, like we would expect to see in a glioblastoma, for example. There's a sense here at the edge that maybe the tumor's falling apart. I don't know if that is necessarily real necrosis, but one can certainly encounter that. I'll just try one more of these to see if there's anything more picturesque. Here we go. So this is a nice example of the vascular proliferation that one tends to see in higher grade gliomas. This even has the real characteristic glomeruloid type proliferation with the multiple lumina within, but even within these kind of adjacent vessels, one can see the endothelial multilayering pretty overtly. So that's an excellent demonstration of that. And here in this tumor, I mean, it's starting to look a lot less round celly, and the perinuclear halos are not as overt, so it might be a challenge to recognize this histologically as a oligodendroglioma. And I think that's pretty characteristic.
I have a question. So if you have in astrocytoma a hypercellularity, but you're not finding mitosis, would you still call it anaplastic astrocytoma or not?
They're just grade 2.
Just grade 2.
No obvious.
It will not be dependent on how much hypercellularity is there to differentiate between anaplastic versus diffuse.
Not usually. I mean, they do tend to correlate, but one can see examples where there's a more cellular grade 2 tumor than one might feel comfortable diagnosing, but it does happen from time to time. And just in the last remaining minutes, this does bring up a very interesting point. So we've talked about the grading criteria for these diffuse gliomas, which is something that we all adhere to pretty closely. I did want to make you aware of a recent change in the 2021 CNS WHO, and something that's been brought up within the kind of interim practice guidelines by the CMPAT Now Consortium, who are composed of WHO contributors. But a lot of these, sort of quote unquote low grade astrocytomas that are IDH wild type, just for the sake of argument, we can go back to that case we were examining earlier on. Something like this, where nobody would ever call this a glioblastoma on any basis. It certainly doesn't have any of the features. But let's say, for the sake of argument, that this tumor were negative for IDH1, and this were in an older individual. And on some genetic testing, we found either a TERT promoter mutation or an amplification event of EGFR or other receptor tyrosine kinase. We know that the natural history of such tumors, irrespective of their histology, is going to be nearly identical to that of glioblastoma. And so there's been a move to change how we diagnose these low-grade IDH wild-type tumors and not call them low-grade. Instead, we have options. There's a very unwieldy title that's been proposed. That's a diffuse astrocytic glioma IDH wild-type with molecular features of glioblastoma. But one can, in the absence of that, probably feel safe just calling something like this an infiltrating glioma and defer grading to molecular testing, especially if the IDH stain or PCR is negative, because there's a high likelihood that further genetic testing will reveal this to be a highly aggressive tumor. So that's the kind of last practice point I'll bring up. And it's certainly kind of a work in progress in the field with the incorporation of all these data, but we are finding some some new ways to approach some previously very difficult tumors. So with that, I'll finish up, and if we have time, I'll take any other questions.
All right. Thank you very much, Dr. Meredith. Thank you for your time.
Thank you very much. I hope this was helpful, and we'll dive into some different entities tomorrow afternoon.
Sounds like a plan. Thank you.
Thank you very much.